All right, let us start this webinar in a good way with a land acknowledgement. We recognize that the work of the Alliance for Healthier Communities and Alliance members takes place across what is now called Ontario on traditional territories of the Indigenous people who have lived here since time immemorial and have deep connections to these lands. We further acknowledge that Ontario is covered by 46 treaties, agreements, and land purchases, as well as unceded territories. We are grateful for the opportunity to live, meet, and work on this territory. Ontario continues to be home to vibrant, diverse Indigenous communities who have distinct and specific histories and needs, as well as constitutionally protected and treaty rights. We honor this diversity and respect the knowledge, leadership, and governance frameworks within Indigenous communities. In recognition of this, we commit to building allyship relationships with First Nations, Inuit, and Métis peoples in order to enhance our knowledge and appreciation of the many histories and voices within Ontario. We also commit to sharing and upholding responsibilities to all who now live on these lands, the land itself, and the resources that make our lives possible. So if you feel comfortable, feel free to introduce yourself in the chat and share which land you are zooming in from. I myself am zooming in from Ottawa, where we are on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. And we recognize the Algonquins as the customary keepers and defenders of the Ottawa River watershed and its tributaries. We honor their long history of welcoming many nations to this beautiful territory and uphold and uplift the voice and the values of our host nation. So feel free to introduce yourself in the chat and share where you are zooming in from. And just some quick housekeeping in case this is your first time ever using Zoom. So we are recording the webinar, and this recording will be shared for everyone who registered and will also be available on our website. There will be a Q&A kind of fireside chat at the end. So if questions do come up, feel free to start typing them as soon as you think of them, and we'll answer questions at the end. And this is how Zoom works. So briefly, I just wanted to, I'm sure most people joining us for webinars have a real knowledge already of social prescribing, but I just wanted to share a little bit. So the work of the Alliance for Healthier Communities and our member centers is grounded in the principles of our model and health of well-being, and our Indigenous-led primary healthcare organizations use the holistic model of health and well-being. So all of our social prescribing work is based on determinants of health, including social determinants, community governed, anti-oppressive, culturally safe. These are the values that form the foundation for our social prescribing work. And in case you are new to social prescribing is connecting people to non-clinical programs and services that support their health and well-being. So just on to the next slide, please. Thank you. So just a little brief bit of information about what is social prescribing in case you are new to the topic. So it could include physical activity, food security, access to the internet, arts and cultures, nature-based activities, social connection, culture as medicine. Many, many different things can fall under that social prescribing heading. And next slide. So the link worker or navigator or connector plays a key role in delivering social prescribing by spending time with clients to hear their needs and understanding their interests. And these are the 5 key components of a social prescribing pathway as we see it at the Alliance. So client, a prescriber, a navigator who can help make those connections, and the social prescription itself. And all along, there's data tracking to follow the client journey, follow up, and improve through a learning health system model. So we have a really amazing panel today. I'm really excited to hear what they have to say and to have a fireside chat after their presentations. So I'm really excited. These are all people who I've seen present and have had really interesting things to say. And before we get to the main attraction of our presenters, I would like to have kind of a opening act, so to speak. And I'd like to just spotlight a few emerging researchers who we've worked with in the past few months or who have crossed our paths. So I'll briefly share a few names. So Linda Manirambona is a PhD candidate in population health at the Faculty of Health Sciences at the University of Ottawa, who's doing a study on primary care providers' engagement with social prescribing programs. And so if you are a clinician and you have not yet participated in this research, there's still opportunity to be involved. And next slide, please. So Kobisha Rajay-Swiran is a Master of Public Health student at the Dalla Lana School of Public Health, who is, her research is around leveraging community asset mapping for social prescribing in the Peel region. And finally, Kira Simons is a PhD candidate in social psychology at Wilfrid Laurier University, and her work is around reconceptualizing aging, agency, identity, and acceptance in Black adults. And a partner with our Links to Wellbeing work. So really just wanted to profile these amazing up-and-coming researchers. And now we'll move on to our presentations. So I'd like to invite Dr. Kiffer to share the first presentation.
Well, thank you for that introduction. As I get started, maybe a couple of things that come to mind. First, as you're talking about your land acknowledgement, one of the things I always think of is how much Indigenous wisdom and worldviews have shaped my own work and my own understanding of, why social prescribing, why social connection research, why health needs to be kind of reconsidered. And I think as a model of care, kind of as you described and showed briefly what social prescribing was, and I think most of our audience probably has a working familiarity with social prescribing. But I think one of the important things to recognize about it is it's really a fundamentally different philosophy that underlies social prescribing compared to traditional healthcare models. And I think that's the recognition that health is not just the, byproduct of, spending money on doctors and nurses and exam rooms and, surgeries and therapies. But it's actually a biopsychosocial production that creates and gives rise to health and well-being. In my work related to social prescribing, what really brought me there was a broader focus on emotional distress. I've worked in syndemics research for about a decade, and syndemics describes the interaction of kind of various problems in society that create a worse outcome than any one of them would individually. So the classic example is like mental health and substance use. And in that work, I again and again found how important people's social relationships were to whether they could recover from addictions, whether they would be at risk for addiction when they use a drug, whether or not they would engage in risky sexual behavior. All of these sorts of things always came back to people's desire to belong and find meaning. And I think most of us have heard that human beings are described as social animals, that fundamentally what we are is a social species. You think of ants, where you really can't imagine a single ant existing, and it's so clear to objectively do that. But the society we've built for us now, it's very easy to imagine a solitary human. We live in cubicles, we travel in single occupant vehicles. We invest a significant amount of time looking into our little rectangles. And so it can give this illusion that we are not social animals. But I think this really reflects a mismatch between fundamentally what we need as human beings and what society has been set up to provide us. So in my work around loneliness, you can kind of see here how we conceive of loneliness from an academic perspective is a recognition everybody does vary to some degree in their level of social need and how much social interaction they need. But when there's a substantial difference between what you need and what you're getting or what you're able to get, that creates loneliness. And in that society in which we live, a substantial proportion of people are unable to get the social supports they need because the natural way that human beings had lived for hundreds of thousands of years before the advent of the Industrial Revolution was in tight, small knit communities. And now we're living in very dispersed, low density networks in which many of us find ourselves isolated and unable to access. So for me, this is really the logic of why we need to start designing societies and systems in ways that really are consistent with indigenous knowledges, that health is a relational thing, that it's the result of the interconnectedness of individuals to each other, to their broader environments, to other animals. And so I just wanted to reflect on that being really important. And so much so, I think a lot of what we do in contemporary social science is really just discover that old knowledge that indigenous people brought. For example, brain studies have found that the experience of loneliness is similar in brain scans as pain, hunger, thirst, suffocation, activating the same life-giving and life-preserving systems that these kind of fundamental needs also activate. And so I think that really highlights that we are indeed these kind of social animals. We depend on one another. And when we don't have that, it's very apparent that a sizable proportion of the Canadian population and population around the globe experiences loneliness on an ongoing basis and kind of gets trapped in a cycle of loneliness. So when a person is isolated to any degree, they begin experiencing loneliness. Just like when you're hungry to any degree, you begin experiencing hunger. You need food, and in this case, you need social connection. That stresses your body's response because loneliness is intended to be a dysphoric experience. And if you think about how we evolved and how most humans have lived up until the Industrial Revolution, people who would feel lonely would immediately be able to correct that loneliness. They'd be able to reach out and find somebody who they needed. And so that stress was easily resolved. Well, today, the way we've built systems, it's not easily resolved. And so people who experience that chronic stress become more socially vigilant. They go into a self-preservation mode, which can look like selfishness or self-interest or lack of social interest. And that social vigilance causes people to withdraw, and then the cycle really starts all over again. And this has really profound effects because that exposure to chronic stress really appears to be driving ill health effects. In our data, greater frequency of experiences of loneliness, so more often throughout your life that you feel lonely, the longer duration of an experience of loneliness. So if you've been lonely an afternoon, that's much different than you've been lonely for 3 years. And the greater intensity of that loneliness, all of us kind of experience that differently. Each of those independently contributes to poor self-rated physical health. And so clearly it's making us unhappy. But as many of you know, it's also making us live shorter and sicker lives. The data comparing the effects of loneliness against other popular benchmarks like smoking, drinking, sedentary living, obesity, air quality, show that loneliness and social isolation, not having a good, proper social functioning, really appears to be worse than all of those traditional indicators. So when you go to the hospital or a doctor's office, you get weighed. The logic should be, well, why don't you also get an assessment for how are you doing? How's your relationships going? Are you able to get the sort of social and emotional supports that you need? And I think this is reflection of that kind of anti-human society, a society of systems and structures that don't acknowledge that we are indeed social animals. That really is a driving problem. And that if we want to correct that, we have to honor the 1946 Constitution of the World Health Organization that defined health as a state of complete physical, mental, and social well-being. We really need to address that social well-being. And this is currently not being done. If you look at the data, we know 80% of your health outcomes come from non-medical determinants of health, meaning they have nothing to do with the hospitals we build or the clinics we create. We know that loneliness has a substantial impact on health and 30 to 50% increase in risk for premature death. We know that sizable proportions of people feel lonely, about 40%, some or all of the time, and about half of that, 15 to 20%, are always or often lonely, kind of experiencing that chronic loneliness that we're concerned about. And yet, only about 5% of public health and medical investments go into prevention, go into the upstream shaping of our social environments. And so, that's why my team and I have spent the past several years developing public health guidelines for social connection, similar to food and alcohol guidelines, as an overall framework for addressing loneliness, both through individual activities, such as building a strong social network, but also through creating environments that are conducive for social connection. And I think our guidelines really highlight that to address the loneliness and social isolation that people experience, you really need a full systems and all of society approach in which not only individuals and their healthcare providers, but also their broader communities and health systems and governments serve a role. And so, this has given rise to a recognition that there are many things that we can do for loneliness. There are many things we can do for different interventions. And whatever the intervention is, they come in different sizes and shapes, and different things are going to work for different people. And that's, again, a major break from traditional Western understandings about, knowledge. The traditional classic way to prove something works is to assign everyone to receive an intervention and then use a RCT to see if it works. Well, if people fundamentally need different things, then an RCT isn't going to tell you what actually works because you're going to be giving some people the wrong medicine. And so social prescribing is really, I think, a genius way to think about people's needs, because it helps us say, okay, well, what happens when you just try to help a person identify what they need and give them that thing? And so what we've moved into is this work around social prescribing to not only develop a consistent model or comparable model across Canada, working with partners like the Canadian Institute for Social Prescribing, the United Way here in BC, which is one of my main partners, and work with these organizations to develop a model and then see what happens when you do that. So that's really where we're at now. I think in the science of social prescribing is evaluating, now that we've shed off some of those more Western traditional ways of siloing and bucketing ideas, and when we acknowledge what Indigenous people have been saying for since time immemorial, that things are interconnected, things are related, that we need to acknowledge that complexity and nuance in life. And so that's what I think is really important for where things are at. But I just wanted to share a bit of that as an opening for understanding, why is social prescribing the intervention that I think a lot of the social health sector is investing in. And I think it's that recognition that we need to do a better job at just acknowledging that humans are fundamentally social animals, that medical and social systems currently don't recognize that well. And therefore, we need systems and processes that can break down those silos and better link different parts of our society together, including our health system, our communities, and so on. So that's my little introduction section, and I'll pass it back to Natasha.
Thank you so much, Kiffer. That was really fantastic. And I will invite our next speaker, Dr. Rosanra Yoon, to come to grab the mic and come to the forefront for your presentation.
Thank you. And thank you for helping me advance my slides. So I'm really thrilled to join this conversation and to really kind of dialogue on the connection between social prescribing and health equity. I think Kiffer has done a wonderful job in laying the ground on a holistic approach that requires a systems approach. And so this is where my program of research kind of resonates. I lead the Better Together Research Hub, really looking at trauma-informed, equity-promoting integrated care. Next slide, please. And I'm a health services researcher, and I'm really interested on integrated care pathways. As all of you know, we're preaching to the choir. We have siloed structures. So social services, community service, medical services, they're all funded in silos. And this is where people fall through the cracks. So I'm very much interested on how do we weave and bring those pathways together, especially for folks who are more vulnerable through structural inequities. And then really using community-based participatory research methods to do that. And I think that's the methodology that resonates well with social prescribing, kind of a holistic approach that's community-based and place-based. Next slide, please. I wanted to share in our time together today some of the work I've done to support community-based participatory research for the Midwest Toronto Ontario Health Team. For folks outside of Ontario, the province of Ontario introduced these things called Ontario Health Teams in 2019, whereby they encourage self-organizing partnerships between social, health, and community agencies to come together to provide better integrated care through collaboration for defined areas. So what you see in the slide is a little map of Toronto, and you'll see the boundaries show the main Ontario Health Teams in the Toronto area, and Midwest Toronto Ontario Health Team is kind of in the middle, and it shows like the area encompasses neighborhoods from the lake to Eglinton Avenue. And so this little piece of Toronto that we are partnered in has like 13 neighborhoods, and they're so diverse. But we do know from population health data that 4 neighborhoods really struggle in all kind of equity outcomes in terms of health promotion. For example, lower rates of cancer screening engagement, high unattachment rates to primary care, socio-demographic disadvantage through poverty and migration status, and all sorts of big city problems. Next slide, please. And so what I want to share with you folks today about the connection between social prescribing and some of the grassroots health equity promoting work our OHT is doing is share with you a program called Open Door that our Midwest Toronto OHT started to implement actually during the pandemic. We found that 3 neighborhoods in our geography really were being hit hard by disproportionate rates of COVID infections, very low vaccine uptake, and compared to the more wealthier neighborhoods in our area. And so we used the link worker model. We used community health ambassadors, people who live in those neighborhoods, have relationships with organizations to reach out and get the response out. Next slide, please. And so after the pandemic, what happened is the funding for those community health ambassadors for COVID stopped. But as an OHT, we had an aha moment. We're like, actually, this really works to reach folks in their naturally occurring relationships with healthcare workers who are actually link workers, community health ambassadors. Can we leverage these learnings for health promotion to really kind of go at the pain points of increased access and equity? And so we did a little pitch to our funder and saying we would like to leverage these learnings for health promotions and better connected services to reach folks. And so that turned into the Open Door program. Next slide, please. And what is the Open Door program? Well, our mission is to be community connected and located. For example, we don't have an office. Our community health promoters and community health workers are from the communities of the neighborhoods we're trying to seek out, and they are embedded. So they have stops. They go to the food banks, the community centers, and libraries, and actually like non-traditional agencies or organizers, so even churches and faith groups. So we don't have walls, and it serves as an upstreet entry point. So we know the folks we need to reach are having a hard time getting to the normal mainstream doors So we want to be an open door where they're at. And literally, it's in your neighborhood. So next slide, please. Our goal as a program is to increase access to preventive and primary care to these primary neighborhoods, priority neighborhoods. And if you're a Torontonite, I think I just created a new name for Torontonians. Um, we're in South Parkdale. We're in the neighborhoods of Fort York. We're in Eglinton West, and we're in Kensington, Chinatown. And so we are literally very place-based. And we have a health promotion nurse, community health ambassadors that provide health education in very non-traditional spaces. For example, in the lobbies of community housing, in libraries and such. And we're there and we develop relationships, as Kiefer said, human contact, developing trust, and meeting, and that what Kiefer said, individually, what do you need? And being there every week. So next slide, please. Like I said, summary of all the places that we go to, literally anywhere in your neighborhood that makes sense where you're at. And shopping malls. We're at a shopping mall. It's the best place to catch people, actually. And so next slide, please. This is a little photo of all the different places that we are at. So if you talk about social prescribing and health promotion had a baby, that's our program. Open Door is social prescribing and health promotion had a baby, and here's us. So we're at you don't have to come to us. We're just in your house where you live. This is that little photo there. You don't see my cursor, but we're in the lobby of an apartment building, and we're just like hanging out. You want a vaccine, you want a blood pressure check. And this is really important in terms of access and in terms of health equity. I just want to bring the lens as the things that keep us well, feeling like you belong, being able to enjoy music, having recreational activity also is a luxury. I say that word intentionally because if you don't have the time and the resources because you're juggling 2 jobs, be caring for a sick family member, and just struggling to put food on the table, all those things that make us feel so rich in our lives, social aspects of belonging, do become luxuries. And so this is like the part where I think social prescribing 2.0 really is nudging us forward. How do we then address those upstream equity issues? And to Kiefer's point, when we get together, there's a real kind of strength in that. So next slide, please. What did we do in our research? We did community-based participatory research, and we did evaluation of this kind of model of getting out into the communities, the community health ambassadors, and this is non-traditional way. And we made a pitch to a very traditional funder and saying, hey, it sounds like, different, but it works. And we showed it by showing reach, showing that we're reaching the most the people who needed our services most. And one of the things we did was we engaged people with lived experience of cancer and cancer survivorship in these neighborhoods to inform the approach Open Door needs to take to address a preventive cancer screening. So next slide. This is a different type of work I do outside of the OHT, but I just wanted to share, another arm of work that I think kind of resonates with social prescribing and health equity is upstream policies and structures and funding that disable connection and community. And one such population, is a good example, is women who experience substance use and criminal justice system involvement. They fall through multiple sectors: correction, social, medical, and whatnot. And this work is led by a group of women's agencies, and you'll see their logos, who, in partnership with women with lived experience, who really identified we need to shift the dialogue from individual women experiencing these inequities to how can the overall structures and systems that impact the quality of life of women with substance use and carceral involvement, how those exact policies, namely housing, employment, all those things that impact social belonging and social connection, how those structural policies need to change. Because often we focus on individuals. And so I'm just showing this because I'm an addiction nurse practitioner who's worked with women with substance use and carceral involvement. And oftentimes it's very hard to give social prescribing to a woman who's just been released from jail with only the shirt on her back and is navigating the shelter system, plus navigating multiple other issues in her life. And to me, it's very clear that her entry point to social connectedness actually needs to start with removing some of the structural barriers that inhibit her access. So I just wanted to show that as another example of bridging health equity and social prescribing. And I think I'm near the end. Next slide, please. And if you want to learn more about some of the stuff we're doing at our hub, here's our QR code to our link to our site. And I'm so grateful to be able to share this space with you.
Thank you so much. I liked that, that your project was if social prescribing and health promotion had a baby, like maybe that will be our new motto moving forward. Love that. So thank you. And now we'll move on to our next speaker, Dr. Caitlin Muhl. Please step up to the mic.
Thank you so much. Okay. I'll just wait for a quick thumbs up to make sure you can see my screen there. Looks good. Awesome. Thank you. Okay, so today I'm going to be talking to you about a social prescribing pilot that took place at the former Vanier Social Pediatric Hub, which is based in Ottawa. So the hub served children and youth who were 0 to 17 years of age, experiencing complex psychosocial issues, and either living or going to school in the Vanier neighborhood, which is one of the most socioeconomically deprived communities in Ottawa. As you can see there on the diagram, it is in the red circle there. Under the community social pediatrics model, the hub team was already providing a very holistic model of care, but due to the socioeconomic challenges that were faced by the families presenting to the hub team found that they were spending a lot of their time addressing really urgent basic needs of the caregivers, like food insecurity, and they saw the need to augment this crucial work with an offering that was focused specifically on the personal dreams and wishes of the children and youth themselves. And so this led to the launch of a social prescribing program that was piloted at the hub over a period of 10 months with the aim of promoting the health and well-being of the children and youth being served. And there was a really strong health equity focus to this program. So with our program being explicitly focused on populations experiencing inequities, we were very intentional in designing the pilot in a way that would mitigate rather than exacerbate health inequities. So there were a variety of different ways that we did this. This included taking action to mitigate financial barriers to participation, such that families did not have to pay out of pocket for the social prescriptions, nor for any of the transportation. We also delivered the program in both English and French to ensure that it would be accessible to both our Anglophone and Francophone communities. And we were also very intentional about meeting participants where they were at and providing them with a supported referral. So another thing that I'd really like to highlight is the strong foundation of community engagement that this work was based on. So altogether, we had 52 community partners with representation from the public, nonprofit, and private sectors, all of whom agreed that they would provide their programs and services at no cost for the pilot. So I'd just like to recognize them and acknowledge all of them. This was a really key piece of making this work successful. So entry into the pathway began at regular hub appointments where children and youth presented to the hub with their caregivers for assessment of their medical and social needs with the hub team. And those who were identified as having poor social health were eligible to participate in the program. So upon being referred, the child was assigned to a connector, and the child connector dyad then met within 1 to 2 weeks, and then they would meet every few weeks again thereafter, either at the hub, over the phone, in the home, in the community, wherever the family preferred. Each session was about 1 hour in length. And as a key part of those sessions, the connector worked with the child to explore their individual needs, strengths, and interests with the help of the Me First 3 Houses tool. So this is a tool that's designed to engage children and youth in identifying what matters to them by exploring their worries, the house of worries, the good things in their life, the house of good things, and their dreams, the house of dreams. So by using this information that they gathered, the child's connector dyad that would then co-produce a social prescription for a child and youth friendly community activity. And then the social prescriptions were written on a physical social prescription pad where the child and connector would both sign it, and then the child would take that with them in the same way that they would with the medical prescription. And then the connector provided a supported referral and met with the child on an ongoing basis to offer them encouragement and motivation, build rapport, monitor progress, and co-produce additional social prescriptions as needed. Now, I won't have time to show you this, but I do encourage you to watch this really great video. We actually brought on a local youth-led social enterprise in Vanier to create a video of our pilot, and it highlights some of the different social prescriptions that the children got to participate in. So I highly recommend you watch it. It's guaranteed to bring a smile to your face. And what I want to do now is just kind of share with you some of the kind of highlights of the work that we did around the evaluation piece. So altogether, we had 43 participants in our pilot, and they ranged in age from 4 to 17. And again, like I said, there was a strong equity focus to this work. And so we had 74% of our participants had a disability, 35% of our participants were newcomers, 77% were from ethnic and racial minority groups. And we also looked at the families as a whole, and we found that 61% of them had an annual household income of 39,000 Canadian or less. And 58% of the families classified themselves as a single caregiver household. Now, in terms of the sessions with the connectors and the social prescriptions, participants completed a combined total of 230 sessions with the connector. So on average, they met with their connector about 5 times. And the participants received a total of 148 social prescriptions. So on average, each participant got about 3 prescriptions. And what we're really proud of is with the big focus in this work on addressing barriers to engagement, we were able to have 91% of our participants complete at least 1 social prescription. And we also looked at the different types of social prescriptions that were given out. We really focused on what mattered to the kids and let them come up with whatever kind of prescription would most interest them. And we found that there were 6 different groupings of prescriptions. So the first one was arts and culture. So this included things like dance classes, museum tickets, music classes. Physical activity was another big one as well. So this included soccer was a really big one, gymnastics, basketball, swimming. Time in nature. So this included a nature camp that was hosted for the children. Career exploration was another one. So some of them participated in Little Medical School. Others went to the police station to spend the day with the police. We also had some practical skills opportunities. So there was somebody who participated in a babysitting course. We had cooking classes. There was a construction workshop. And then finally, entertainment and leisure. So this included tickets to music performance, to sports events. We also had a couple of the kids go on a trip to Disney World, which was pretty amazing. So what I want to highlight, just to wrap this up, is that this work was about so much more than just having fun. For sure, it was a lot of fun for the kids to engage in these prescriptions, but it was about so much more than that. And the concept that I'd like to talk about here is something called self-determination. So this refers to having the ability to make one's own choices and feeling a sense of control over one's life. And we know that self-determination plays an important role in positive child and youth development, which ultimately lays the foundation for thriving in adulthood. And so one thing we wanted to do in our evaluation was understand the ways in which our program may have fostered self-determination in the participants. So we use this theory called the Circle of Courage. It's a child and youth-focused theory on self-determination that is grounded in the wisdom of Indigenous peoples and modern scientific thought. And so by using this theory, we found that social prescribing fostered generosity, which means the child's character is nurtured by concern for others so that the child can say, I have a purpose for my life. So for example, the children participating in the police station visit, they found that they were then looking forward to that kind of opportunity and wanted to have that career to be able to serve their community. Others, for example, whatever they made in their social prescribing activity, they then wanted to give to their family afterwards. Belonging was another one. So we found that the program fostered belonging, which means the universal longing for human bonds is nurtured by relationships of trust so that the child can say, I am loved. So this manifested in a number of different ways. This included the relationship they built with their connector, with other children in the social prescribing activity, with the adults running the activity, with their family members as well. They often got to engage with their families in the activity, as well as with their community as a whole. Independence was another one. So this means the child's free will is nurtured by increased responsibility so that the child can say, I have power to make decisions. This was a big one because of the fact that co-production is so important in the social prescribing model. The fact that they were asked what mattered to them, what their dreams and wishes were. This is also something that was seen. And finally, mastery. So this means the child's inborn thirst for learning is nurtured by learning to cope with the world so that the child can say, I can succeed. And so in many cases, the children actually picked their prescription based on a skill they wanted to learn. And so whether that be they wanted to learn how to swim and move up levels or learn about cooking or many different skills where they were able to kind of develop those skills and then see how they were able to contribute to the world and see what that would mean for them in their future. So that was some interesting work that came out of it. And what I'd like to kind of end off with is perhaps my favorite quote that kind of relates to this idea of self-determination and how we're able to find this in our evaluation. So in our interviews, one of them in particular, the interviewer asked, did you find that participating in the social prescribing program changed how you feel? And this participant, who was 9 years of age, they said, no, the only thing that it made me feel was get more confidence that I can achieve my dreams. So I'd like to end off there and just finally share some acknowledgements with our funder for this work, with all of the community partners, without whom this would not have been possible, the Community Services Center where this work took place, the Children's Hospital, and then everybody listed there, in particular the Hub families. So thank you so much to everybody.
Wow, thank you so much. I think I need to go into my house of dreams and think about what my dreams are. That was really great. So now we'll take a moment like to have a fireside chat. So I know there's a couple questions that have been asked, but if anyone else has questions they'd like to share for our panelists, this is the time. We're gonna have a conversation between the four of us. So let's see if we can, yeah, perfect. Actually, I wanted to kind of start as we come together. I was thinking about what you were saying, Caitlin, about self-determination and co-design. So like, what do you like? I know you talk a little bit about like empowering kids, but what role do you think that community voice, that self-empowerment, that co-design go into making social prescribing more equitable? And maybe I'll start with you, Caitlin. I'm switching things around a little bit, but yeah. So
Yeah, absolutely. I think especially at that level of creating the social prescription, I think that really is important because especially when it comes to children and youth, that's my population of interest, of course, it's kind of unusual in that kind of encounter at that age to be asked what matters to you, right? And so to kind of flip the script a little bit and ask somebody what matters to you and together create that prescription, that's something that's really powerful and it kind of shifts that power dynamic a little bit. So yeah, I think that's really key. And what differentiates this a little bit from other interventions is the fact that we're asking people. We're not just sort of thinking, oh, you might like this and give you a list and send you on your way. But that co-production piece is really so key, especially when it comes to the equity part of social prescribing. So.
and maybe I'll move next to you, Rosie. Like you talked about the importance of having people from the same community who were those health ambassadors. And so that to me speaks a little bit about self-determination and co-design. I don't know if you want to say a bit more.
Yeah, and I think it's really central to approaching like from an asset-based perspective that we look at communities, especially from I wear like a OHT hat. And so like you look at population health data and we call even our language is interesting. Like that's a hot spot area, right? And you know, it's problematic. And then it's this complete reorientation to no, there it's a neighborhood and we all live in neighborhoods and we're citizens of society and we go about our day-to-day lives. And if health happens in where we live, work, and play, then the approach is what are the assets of this community? And the assets are people. And you'll see in every community the lovely neighbor who cares and knows you, and you know them, and there's relationships. And to Kiefer's point, as we started off, like, you know, indigenous ways of knowing, but also human ways of being with each other is non-problematizing, non-medicalizing. And you know, that co-design, I think really to, you know, it's a in the research world, it's like a, you know, it's the methodology of doing things. But if we, and in fact, real co-design is actually leaning in and following the lead of the very people you wish to design the solution for. And so it's beyond any method. I think it's a way of working, a way of planning. And, you know, I think OHTs in general are a big experiment, but I hope that the experiment is positive. And one of the good outcomes of OHTs is that perhaps our systems can really change the ethos to evaluating what matters to people. Let those people define what that means and let the researchers figure out how to measure it. And the solutions don't have to be done to people. In fact, we knew Open Door was not our idea. Open Door came about because of community health workers who live in those communities who were just doing what they knew already works, which is relationships, knocking on doors, and low barrier access. And that was not something that was done to them. That was something that was already being done. And it just took a pandemic for us to name it as such.
Mm-hmm. Kiffer, do you have any thoughts on like co-design when we talk about belonging or isolation? Like rather than me telling my mother to go to the seniors center, asking her what she would like to do with her time.
Yeah, I think one of the important things we've seen in our research is that particularly when we're thinking about these social aspects, individuals who I think differ, say individuals who are lonely, individuals who are living in poverty, they really do have fundamentally different life experiences that are going to determine whether or not a program is going to be effective and working for them. And if you don't attend to those, then you're going to just waste money, right? Because you know, we know if you look at almost any public health intervention that we've tried on any health issue, really, they don't really work they don't really work if the access piece is not improved, right? And I think that is really just the acknowledgement of, again, you know, getting away from an anti-human way of designing things. I think recognizing that our systems, the way they are typically designed, is with different priorities in mind: the priority of efficiency, the priority of low cost, the priority of ease on providers. While all of those aren't bad criteria to optimize for, but if you're not optimizing also for the user experience, the user need, then it appears that public health systems just don't work. And so, you know, we see that again and again when it comes to really great interventions, that if only people would participate. And I think that we have to remember, we have to treat the client in front of us. You can't treat that imaginary client. Oh, if only people would do this. If your solution is, if only people would, then you don't have a solution at all. And so I think that's something that, you know, the co-design movement within social prescribing has really understood from the get-go. And it's something that I think we've learned through a long experience of repeatedly failed public health interventions. You know, if we look at things like vaccines, if we look at things like healthy eating, if we look at things like exercise, again and again, the access piece is what's really critical. And access is a complex, multidimensional construct that is person specific and community specific. And so, yeah, I 100% agree with Caitlin and Rosanna. And these examples that they've shown are exactly, I think, what is needed to improve. And in fact, we probably need to go much further than we've been able to go so far. But of course, the existing structures are going to try to reinforce their ways of doing things to optimize for efficiency and low cost and those sort of things, which is one of the challenges that we've got to figure out. How do we do both? How do we achieve all these goals at once? And so that's, I think, where the state of the implementation science research has really taken us.
Yeah, I mean, something I heard from all of your presentations were that we need to shift the systems and the policies that impact like it's like the structural systems and the structural policies are impacting our sense of belonging, our sense of social connectedness. I don't know, is there any like how can we change some of these structures? How can I like both all of you talked about like instead of a top-down approach, like a bottom-up, an upstream approach. Do you have any thoughts off the top of your heads, maybe?
I mean, I think, I think some of that's going to happen naturally. And we shouldn't undermine the extent to which progress is occurring. The fact that this webinar is taking place, I think, is a signal of what's going on in our system, that we are recognizing to move there. I think increasingly so, things like medical training and training of professionals in universities and college settings are increasingly teaching this worldview. We're getting away from biomedical models and towards biopsychosocial models. We're getting away from top down to bottom up. So we're doing a lot as a sector to recognize these things. And so I think some of that's going to have to happen naturally as we see, the current generation of thinkers rising up and taking control of the systems. Not in a revolutionary way, though that's okay if that happens, but in just the standard way of that, ideology and thinking changes over time. I think is what's going to really keep that going is, and one of the areas that I've been concerned that we haven't quite got there is the community knowledge of these sort of things, right? I think the demand for this sort of service and care is really missing from important discussions when it comes to primary care provider crisis and the healthcare access crises, right? I think those are things that the general public is thinking about and having conversations about. And so I think that we need to make sure that they also have demand for good models of care that are actually meeting their needs, like social prescribing. And so I think this sort of public diffusion is something that's really going to help accelerate us in that direction.
And Rosie, it looked like you had some thoughts about like these structural barriers to connection and belonging.
Yeah, structures matter. So I think social prescribing is not in the wheelhouse of healthcare at all. It's in the wheelhouse of civil society. And I think it's how our cities are designed. Is it walkable? Is there green space? And I work with women who have carceral experience. What does it mean to have a criminal record and your employability? What does it mean to not have the right credentials to that job or promotion, to not be able to afford rent? Like all of those things are structural. That leads to housing policies. And people say like, who's the domain of social prescribing? And I would say everyone. And can I say something radical and maybe crazy? It's crazy. I disclaimer, it's crazy, but I wish we could come to a point where we don't need social prescribing. So because our structures and policies and built environments of our lives are conducive to well-being, not being lonely, to all those things. I wish we could come to a point where we don't need social prescribing. So I'll use another weird analogy from Cliff Ledward's from Access Alliance. So it's not mine, it's his analogy. He uses an analogy of like airlines. So there's like a Star Alliance, which is like an airline thing where if you're flying like one brand of like I'm gonna make it up. Maybe I'm not supposed to say name. I'm hypothetical. I'm supposed to fly to Berlin, but my original flight was supposed to be on like air carrier A, but air carrier A get delayed. So because of the Star Alliance thing, they seamlessly transfer my flight to air carrier B. But to me, as a passenger on the plane, I don't know that's happening.
Mm.
And so I wish we can come to a point in our society where we don't need social prescribing, because where I live, where I work, how I live my life and be with others is done in a way where the structures and policies and funding enable that good life.
Mm, mm. That really sounds like a call to action. Like, I think it's okay to share radical ideas here. So as we come to the end, and I'm going to put the QR code up for our webinar evaluation, or maybe someone can put it in the chat for me. I wondered also if there was other calls to action, maybe from Caitlin or from Kiffer. Do you have a call to action to end our webinar on? We're gonna making the systems easier for people to participate.
Yeah, I just wanted to maybe comment on that idea of like not needing social prescribing. And I think a successful social prescribing does like eventually, theoretically, eliminate its need, because we are taking individuals, we're connecting them to the community, and every person that we can engage in community is another person that somebody else can connect with, right? If we really believe social capital theory, if we really believe that community cohesion and these sort of social processes are important and real, then I think that's going to happen naturally. So I think like as we think about social prescribing, we shouldn't just think about the individual, but what are the benefits to the community that are occurring? No evaluation is really capturing that. And so I think we're actually missing out a part of the richness of social prescribing, giving people those skills, because even they might not stick in that community that you prescribe them to. They might go and start their own community because of the skills, because of the capacities they're building from being in community with other people. And so I think my call to action is never underestimate or never forget that that's all that exists. At the end of the day, it's us as individuals, as humans, as communities working together to create our circumstance. You feel like oftentimes things can't change. That's a status quo bias. Our brains are really set to be fearful of change. But if you look all throughout history, all the major innovations in health and society have come because we've been able to leverage that social capital mechanism. You put people together and great things happen. And so let's do more of that.
That self-determination piece too. Yeah. I'll give the last word to you, Caitlin. Any calls to action for us?
Oh gosh, the pressure. I would just echo what Kiffer and Rosie have both said. That's really wonderful. And I think too, for anybody who is venturing into any kind of social prescribing work, just to have equity be top of mind and just like cognizant as you're designing these programs, like, who are you reaching, right? Like, who are you involving in those conversations, and how are you thinking about those barriers and how you're going to address those to ensure that you are helping to mitigate those inequities that people are experiencing rather than exacerbating them. I think that's really key. So something that we really thought about in our pilot, and if anybody else is doing this work, I really encourage that.
Amazing. Thank you so much. It was such a pleasure talking to you today. If there's anyone in the audience who's new to social prescribing, we have our bi-monthly Ontario Social Prescribing Community of Practice. We have our online learning modules on health equity focused social prescribing and many other resources on the Alliance website. So thank you everyone for joining us today for this amazing, it was just like really an honor to be with this panel. And I wish everyone a really great day. Take a moment to fill in the evaluation, please.